any model of policing, there are going to be challenges and limitations. So I'm just going to go through a few here. First would be the shortage of specialists in a lot of cities. It takes a lot of training, a lot of schooling, a lot of licensing to become a licensed counselor or psychologist. Some less training for, CIT certs and stuff, but again, shortage of people in the psychological field to aid in these types of calls. Next would be limited training for 911 dispatchers. It is a problem of limited training for the officers, but it is a problem in training for the dispatchers as they aren't properly trained on who to go to when these types of calls arise or which situations require which type of model. Again, the co-response model or the mobile model, meaning that an officer and a specialist will go together in the co-response, or in the mobile, a specialist will go on their own. Next would be funding shortages and staffing constraints within the police force. Lots of police force departments are underpaid and don't have enough funding to allocate those types of resources. Next would be safety concerns in high-risk situations. This again goes back to the 911 dispatching call. Say they aren't properly trained to decide whether or not this situation requires a police officer and a mental health specialist, or just a mental health specialist, or at the time the call comes in, it's not a dangerous situation, so they just send a mental health specialist. Mental health specialists are not trained in use of force, or forceful de-escalation. So if they are sent into a high-risk situation, they have no protection now. They are not trained. Rural areas specifically face long travels and fewer resources. They lacked mental health infrastructure. And again, not all cities have lots of people to allocate to these types of responses. And again, with any policy, there's going to be challenges and there's going to be limitations, but crisis teams are not a one-size-fits-all situation. It's going to be work, it's going to be progress, and it's going to be over time. It doesn't happen overnight. Next, we are going to talk about the future of crisis response. We are going to be talking about how this is going to benefit the system and how we can move and make steps to get to a better system for crisis care. First would be the expansion of integrated crisis systems, increased use of hybrid responder models, again, training in 911 dispatchers and allocating who will go to which types of situation, if they need the police to come with them or if the specialists can go on their own. Stronger partnerships between police and mental health agencies. This is a very crucial one as mental health agencies aid in a lot of police matters. As we've seen, 1 in 5 calls, about 20% of calls, involve a mental health crisis, and gaining a stronger relationship between police and mental health agencies is going to aid the community, which is the police officer's job as well as the mental health agency's job. They both have the same goal in mind, to help people and to aid in community safety. So better relationships between the two will be proactive. Another would be growing emphasis on trauma-informed care. This would be helping officers, 911 dispatchers, and even mental health specialists who aren't trained in immediate crisis intervention or 911 dispatch calls, emergent situations, explaining to them types of trauma, being able to notice and recognize the signs of what you are dealing with. And ultimately, this is going to be a movement towards safer, more health-focused public safety. The main goal, again, for everybody in the police agency, dispatch agency, mental health agencies is about public safety. New programs are being implemented nationwide, and many cities are exploring integrated crisis systems, linking police, EMS, hospitals, mental health centers to move towards this trend. And the trend suggests a shift towards reducing harm. That is the goal here. When approaching a mental health situation, an emergent one is reducing harm to officers, specialists, and the people involved. In conclusion, mental health crisis response teams represent a major shift in how America approaches public safety. By bringing clinical expertise and compassion into emergent situations, these teams can offer a path towards safer and healthier communities. They reduce harm, they reduce arrests, and they reduce escalation in situations where it is unnecessary. They reflect a major shift in modern policing. Mental health specialists help communities stay safe and supported alongside the police. And better care for mentally ill individuals strengthens the relationship between the police and the community. Police brutality has become a very big thing, and in a lot of cases, it is a system of mental health or a situation of mental health. For example, Sonia Massey is a woman who was shot in her home after experiencing a mental health crisis, and an officer responded, and he unfortunately fatally shot her. Had a mental health specialist been used upon the arrival on the scene, it could have been a completely different outcome. And as cities expand on these programs, the United States may see a more effective and compassionate approach to policing. And mental health crisis response teams represent one of the most meaningful innovations in modern U.S. policing. It is imperative that we handle the issue of mental health crises against police, not against police, but the situations being handled and the outcomes of them. To end this presentation, here is a list of references I used to create this slideshow. And a big thank you for watching. Again, this is presented by Lena Sabran Santiago for a video project about United States policing in the class police processes. Thank you for listening.